Welcome to the St Emlyn's podcast. I'm Iain Beardsell.
And I'm Hutch.
And I have grabbed Hutch to come and just do a quick review of some of the talks we've heard at Trauma 2030. After his astonishing appearance on the podcast recently, where we were at another conference and we talked a bit about cognitive halos and decision-making. And as I saw he was here, and he's been part of the St Emlyn's team for a while, I'd use him to try and go through some of the learning points we've had over the last couple of days of what has been a really interesting time here in London. So this is Trauma 2030, run by the Institute of Pre-Hospital Care, part of London's Air Ambulance, for whom Hutch works. And it's been an interesting couple of days. We started off on day one really talking about exsanguination. And one of the big points was about damage control resuscitation. Hutch, what did you take from some of those things that we learned?
I think the talks yesterday morning really nicely reflected the current modus operandi of London's Air Ambulance. And given the sort of demographic and what we're exposed to trauma-wise in London, the service makes little to no apology for being targeted at that specific group of exsanguinating, dying patients, often as a result of penetrating trauma. And so some of the key themes that emerged from that were a real attention to detail and purpose about deeply analysing where, why, and how patients die from bleeding and what we can do to tackle that. And probably the foremost theme that has emerged from that deep analysis is speed. And we've spent years increasing the availability and number of pre-hospital interventions, all at the expense of speed. I think we've probably learned to evolve that strategy now in London. And in much more detail and much more complex ways, we've determined ways to reintegrate speed and up-prioritise progress against things that we thought may have been more important in the past.
I think you're right. Some of the terms we've heard in the past were stay and play and scoop and run. And they almost became very poorly thought of, that you shouldn't describe patients in this way and that actually scoop and run was a bad thing. And you should stay and do all the stuff you've been trained to do. But we've heard really good talks from Zane Perkins and others about the time frame that you have to get the acutely bleeding patient into a hospital. And we will have some more podcasts coming from some of the faculty about this in more detail. But that's really struck me, that it's no longer a bad thing in the right patient, in the right circumstance, to get them in an ambulance and get them to a hospital.
Yeah, completely true. As long as that is a highly conscious decision delivered in a method which you've thought about, rehearsed, practiced, and that case is subsequently highly governed. In that case, with a lot of ability to intervene en route, it does appear to be a safe and effective method.
That's one huge thing that struck me from the whole time, is that London is clearly very thoughtful, as many pre-hospital services are, about how they're doing things and why they're doing things. This is all based on data. We've discussed on St Emlyn's the series from the Resuscitative thoracotomy that was published in the last year or so, looking at the experience over the last 10 years and who it is who survives and who it is who dies and what you need to do with them. And that's another thing I've taken away from this. It has been quite London-centric, but in a way I haven't minded that, because looking at a specific area and a specific service does give you an insight into how people think and how they work in that area. So time is clearly important. We've learned that getting patients to hospital is the key for some of them, and that just doing stuff on scene because you can isn't necessarily the right way forward. And it's also about the right patient. And Laura talked about resuscitative thoracotomies and when to do those. And again, we'll have a longer podcast about that coming out in the future. But that is something that really struck me, that it's hard to get people to stop doing things. And that's a real tricky thing. I know that when I was doing pre-hospital care, the opportunity to do these procedures was exciting. And now what we're saying is, you might think it's an opportunity, but we actually don't really want you to do it.
That's right. The resuscitative thoracotomy is a great example, because when it was introduced, as it happens in London, it was introduced as a potential treatment for someone with cardiac tamponade. And then over the years, that mission crept in London to be a potential treatment for people with other pathologies that had caused TCA. And that creep probably crept further around the country, if not even wider than that. As a result of the 21-year audit, which I've written about on St Emlyn's actually, the absolute value of thoracotomies delivered by London HEMS this year is almost half that of last year. But what is completely unchanged is the number of survivors. So this is really important. We're learning much more accurately how to select the right patient who may benefit from a very invasive technique.
For me, that meant that if you have a patient in traumatic cardiac arrest, you've got to think, It can't just be airway, thoracostomies, proceed to thoracotomy, put in big lines, give a load of blood, and as Dan Nevin said, and then declare them dead at scene. There's more to it than that. It's about choosing your patient wisely and actually choosing what not to do. And I think that's not straightforward.
London HEMS teaches like quite an academically rigorous approach to these patients. The question that comes up when you're ever discussing these is, tell me, Hutch, what is killing the patient now? And we've learnt that we've had to reintroduce history, examination, diagnosis plan to the management of patients that are in arrest. It's all very well and good saying you've got your potentially reversible causes, HOT, so just hit them all. It's not enough, and it doesn't get the right thing done in the shortest available time frame. There's no reason not to do history examination diagnosis plan. We do it for all the other patients that aren't having CPR, and we've realised it's important to do it for the ones that are as well. No surprise there, really.
This whole conference has been focused on what might happen in the future. It's deliberately called Trauma 2030, which is only 5 years away. And if I look to where we were 5 years ago, it doesn't feel that long since that was happening, actually. And Trauma 2030 will be on us soon. We've talked about some techniques and other methods of resuscitation which feel otherworldly to me. And ECMO always raises its head. And we've had lots of sessions about ECMO. Some of it has felt a bit, it could only happen in London. But the more I've thought about it, the more it feels, actually, maybe not. Maybe this is something that might be relevant to those who don't work in London, work in smaller centres outside the capital. You've got real experience of ECMO, Hutch. Where do you think it might go?
You're right. We are gifted in London to be able to offer ECMO to patients because we have a lot of ECMO centres, and we have a lot of ECMO centres because there's a lot of people in London. I feel sad that feels like a barrier to other places being able to offer the therapy. And I would just ask people to look a little bit beyond our shores, really. And this is not to say that the UK has a bad system for offering ECMO. That is not true. And particularly for respiratory ECMO, we have what I think is probably a world-leading system for offering ECMO. But having got such an excellent, robust system for specifically respiratory ECMO, I think that has slowed the growth of other centres being able to offer other therapies. And that growth has not been slowed down in other countries in Europe. So it's really interesting to contrast. There was a paper written about this, actually, demonstrating the number of VA ECMO runs and ECPR runs delivered in the UK. And in contrast to Europe, we are way out of kilter. It's very low. So one of the things that I think this conference was a bit of a attempt at a call to arms for was to say this is a therapy that is done and it can be done. And these are the patient groups that it probably should be done for. And how can we find a way to accelerate that in our existing networks and perhaps expand those networks more widely?
It was definitely something that's made me think, because I'm a bit of a naysayer, I'm a bit of a pessimist about these things, particularly when people come up and present their numbers and they're all shiny. And yeah, but what in the real world? When I'm on an emergency department shift on a Saturday evening, what does this mean to me? But I have been a little bit persuaded that actually technology may improve, the costs may come down, we may be able to direct this more accurately to the patients who need it. And actually this could be in 5 years' time something that I might be thinking about doing.
And I think to support that idea, one of the really nice talks yesterday afternoon was about the trauma shock call, which I think is fairly unique to Barts Health, whereby the team in the Royal London Hospital can say, we have a patient, code red, with, we think, cardiogenic shock as a consequence of trauma. And that trauma shock call gathers remotely all the relevant experts in managing cardiogenic shock after trauma from surgery, anaesthesia and ECMO, which is offsite. But it bridges the gap between the two hospitals and bridges the gap between what has traditionally been two very separate services, emergency medicine trauma and cardiac ECMO. I think that is something that could be expandable to other centres, and trauma centres could partner up with their cardiothoracic services and develop a shock call concept whereby, who knows, maybe one or two patients could start being able to access these services that couldn't have done in the past.
We will have a podcast coming up with Jay and Sean talking about that shock call in more detail. But the thing that struck me from recording that was, like lots of these therapies that are at the forefront, it is dependent on enthusiasts and experts and actually people giving of their time. So this idea of a shock call, there are people who are at home with their families who will still take the call, even though they're not job planned to be at work. They're not on call, because this is something they believe in and something they want to make happen. And that's another thing about coming to conferences, isn't it? It can reinvigorate your enthusiasm and remind you that there is more to life than some of the crowded corridors we have to work in and the other areas where it just feels a bit much some of the time. Hutch, what will you take away as being your abiding memory, apart from seeing friends and colleagues and sharing experiences with them? What will you take back to your unit from the last day or two?
I think my abiding memory of this meeting is very similar to how I would answer the question people often ask me, which is, Hutch, what's the best thing about working for London Hems? And this is not me being a sycophant. I'm being genuine. Most people expect me to say it's doing thoracotomy and putting rubber in and having loads of blood transfusion and having amazing survivors. And yeah, London Hems does all of those things. But for me, that is not the most impressive thing the organisation does. The most impressive thing, it is absolutely contagious and infectious, is the utter determination to really look absolutely critically at, are we doing the right thing? And if the answer to that is no, which it often is, can we do something today or tomorrow to change it? That's what's made London Hems progress as much as it has over the years. And I think that feeling has been really palpable in this meeting. And I'm in a good position to be able to qualify that as someone who works clinically in the team and has then come here and seen people from all over the UK and further afield be immersed, I hope, in that feeling that I get for working for this organisation. So if I was to take one thing away, it's that. It's be absolutely passionate and determined, to be inquisitive and to make progress.
And we're really lucky. I had some time with Anna Dobby, who's the clinical lead for London Hems, and we chatted through leadership, and there'll be a podcast about that coming out too. London Hems is one of those funny phrases, isn't it? When somebody says, I'm part of London Hems, if you've not been part of London Hems, sometimes there's a little sigh of, oh, I'm not part of the club, and oh, I'm not one of you. And it's been held over the last 20 years, a sort of badge of honour that if you've done London Hems, you're the guy. I don't think that's the case with the team anymore. It feels very inclusive. The team have been very kind to invite me to come and watch them do some work as well. And it does feel like all of the other activities, which I hadn't quite realised until Anne Weaver spoke this morning, about the extended research, the violence reduction, the charitable endeavours they're doing to try and take it beyond the pavement and the field, is really to be congratulated. And I'm a naysayer too and a bit of a pessimist, and I think I've been won over, and delighted to have been here. Hutch, thank you so much for your time. I've taken you away from your lunch. The sessions are going to start again for our final afternoon, but I just wanted to grab you before it all finished. A pleasure as always, and a little happy Christmas to all our listeners if we don't get a chance to talk again. Look after yourselves and do the best you can in what are trying circumstances, but know that there are people pushing the boundaries, and if you want, you can be part of it too.